Good evening. On behalf of Centaur Pharmaceuticals, I would like to welcome the speakers and moderator for this webinar. I would also like to welcome the audience for this respiratory webinar, which is on three distinct topics. At the outset, I would like to thank Centaur Pharmaceuticals for sponsoring this webinar. Though they don't require any introduction, but it is my privilege to introduce our first speaker, Dr. Shishir Modak. He is a consultant pediatrician at Dinanath Mangeshkar Hospital in Pune. He is going to speak today on asthma and wheezing in below 5 years children. Welcome, sir. Our second speaker is Dr. Vijay Warad, who is a consultant pediatrician and an allergy specialist at Sai Allergy Hospital in Pune, and he is going to speak on improving respiratory specific immunity. Welcome, sir. It is also my extreme honor to introduce our moderator for today's webinar. He is also going to speak on approach to respiratory problems in current situations. He is Dr. Pramod Jog, who is Professor of Pediatrics at D.Y. Patil Medical College, Pune. He is also the past president of IIP. Welcome, sir. I would request our audience to key in the questions which you have in the question box which is below the video window. Now, without any further ado, I would request our speaker and moderator, Dr. Pramod Jog, sir, to take over the proceedings. Over to you, sir.
Okay. Thank you, Mayuresh. I will just share my screen in a minute and then start the discussion with our virtual friends. You know, these days, all the webinars, we are having the discussion with virtual friends. And all these days, we have been used to speak to the faces directly. And whenever I speak, I always remember of the Hindi song, you know, like "Jo baat tujh mein hai, teri tasveer mein nahi." You know, so that is something one must remember. Yeah, actually, these webinars for people like me is a big embarrassment because I simply cannot see any face in front of me. I have to speak to the screen, but that's fine. It's a part of education. I also thank you for this platform being made available by Centaur. I also appreciate the presence of Dr. Shishir Modak and Dr. Vijay Varat. I will give you the initial talk on respiratory infections in the current scenario, followed by my talk. Dr. Shishir will speak on asthma, and then Dr. Varad on immunity in relation to the respiratory system. And as you can see, I have a declaration which I have to make these days for the patients that I am under the age of 65. So I am in the low risk category as of now. I am immunocompetent. I am COVID-19 negative. Okay, so because patients also have started asking whether Dr. Jog is positive or negative. So one has to be very clear. And this date of 18th May is AC. You know, just as we have before Christ and AD, it is now after Corona and before Corona. So this is 18th May. And let us start with the discussion. And I call this not a webinar, but it is a Covinar. So it is a COVID season webinar. And we will start with that. The first question that is troubling everybody in the mind is "Jaane kahan gaye wo din?" All those gastros and typhoid and hepatitis A have gone. Hardly, you know, a few patients are coming for illnesses. Majority of them are asking only for vaccination, but they are not really turning up. And that's why many doctors are getting withdrawal symptoms. Of course, people get withdrawal symptoms because of many reasons, but these withdrawal symptoms are because of the reduction in the number of patients. Anyway, we will have some short background of this, coronavirus. These are three crooked corona brothers. Remember, these are the RNA viruses. Most of these respiratory viruses are RNA viruses. And the peculiarity of RNA viruses, say like influenza, you know, is that they mutate very fast. That's why we know that every year we have to immunize our children and ourselves with flu vaccine, which is different one every year. And corona is not an exception. It created a problem in the year 2002, 2003, when we witnessed severe acute respiratory syndrome. That was SARS-CoV, that was number 1. Number 2 was 2012 and 13, when it was the Middle East respiratory syndrome, which affected people in Saudi Arabia. And then it was MERS COVID, not COVID, but the coronavirus. And then 2019, 31st December, we all know that China reported to the WHO about these increasing number of cases coming there. And later on, WHO titled this as the novel coronavirus. So it is COVID-19. And this virus, as you can see, looks, like corona, that is the crown. You can see the spikes at the top. And if you see these viruses, the bats are supposed to be the natural reservoir, everyone knows by now. And the novel species, they arise from the combination of the bat virus and the virus of the other mammals. These proteins that I showed you in my earlier slide, they are the ones which are important. And one of the most important is the spike protein, S protein, which creates almost all the problems. And as I told you, if you go down the memory lane of corona, you know that from 31st of December till today, that is 18th May, everyone is aware as to how the disease spread within China. Then it spread to Italy, and then to Spain, and then to US. And India is also fighting hard to combat this problem. Okay. In short, about this pathogenesis, so that we know what happens in the respiratory system. Basically, as I told you, those spike proteins are the ones which create problem. And they get attached to these ACE2 receptors, which are there on the ciliated epithelial cells in the human lungs. Once they get attached, they start replicating. And there are certain phases through which the entire illness goes. So in the initial phase, which is known as the viral phase, the virus continues to replicate. And if a person has very good immunity, he has a good diet, he is taking good sleep, he has good exercise, and mentally is positive, and so many evidence based and non evidence based things during this particular period, if everything is fine, then he usually overcomes the problem. But if he has some risk factors, he is above 65, above 70, above 80, he has diabetes, hypertension, and if he is unfortunately on some anti-malignancy drugs, is immunosuppressed, then the viral replication continues. And these viruses, they release some pro-inflammatory cytokines, and these cytokines are the main reason for all the problems. And they produce a problem which is similar to what we pediatricians call it as HLH, that is the hemophagocytic lymphohistiocytosis, where there is macrophage activation, and so many enzymes which come into the circulation, they are the because of this HLH. Now the cytokine storm will affect the lung parenchyma and produce ARDS, or it will produce problem by involving the lung vasculature, these are the blood vessels, and it may produce thrombosis. So this thrombosis will lead to abnormal coagulation parameters and increase in the level of D-dimer and others. So you should know what exactly happens. Then that's why I told you about this pathogenesis. And the disease typically goes through certain phases. In the initial part, there is incubation period. That means there won't be any particular clinical picture which will be seen. But after an incubation period of average 5 days, which has a range of up to even 14 days, but roughly after 5 days, usually the presentation begins, and the patient starts showing the symptoms like fever, cough, and all. If it remains only restricted to fever and cough, then it is said to be a mild disease where there is no pneumonia. If in case it progresses down to the lower respiratory tract and produces pneumonia, the respiratory rate will increase. And if it further progresses, there will be hypoxia, and it will be called as severe pneumonia. And this child may become critically ill, and that would be a critical phase. But roughly for our general pediatrician, they can remember that these 3 stages, like no pneumonia, pneumonia, and severe pneumonia. And what is the meaning of a close contact? Now, simply when a patient comes and just speaks to me for a minute and goes out, usually he won't infect me. But if it's a contact for 15 minutes, if he's speaking to me for a very close distance of less than 1 meter, and if he doesn't, he has not worn the mask, then, he becomes a close contact. So our colleagues should know about this. In children, this particular disease, in 90% children, it is either asymptomatic, mild, or moderate, and very few become serious. And why this particular difference in children and adults? This is because these children, they are not exposed to a great extent to the virions because they are at home, and their respiratory tract is healthy. They are not exposed to the pollution, smoking, and all. And in case of elderly, the situation is different. Their immune response is qualitatively different. It is said that there is something called as immunosenescence. That means the immune system is aging. And many times in children, there are other viral infections also taking place, and that's why there is a direct virus to virus interaction, and there is a competition between different viruses. And these ACE2 receptors, which I told you, they also differ. The expression of these receptors is different as the elderly and the children are concerned. One should also remember that small number of reported cases are there. Children, the number of cases reported is small, and that's why it is very difficult to delineate the clinical characteristics. And there has been a review of about 2,143 children, which showed that 13% children are asymptomatic, and these asymptomatic children, they are less likely to be tested. They are asymptomatic, they don't have symptoms, but they continue to transmit the virus. So it is important to note that. And that's why whenever any child comes to me for fever and cough, and if in case he is COVID positive, when he goes back, he has to be quarantined at home, because he is the one who can transmit it to the grandparents and the high risk people at home. That's very important. And the another relation of BCG vaccine to the protective role against COVID was also discussed, and nobody is very clear about it. But in general, WHO doesn't support it as of now. And there is also heterologous immunity to other pathogens. Particularly we give so many vaccines to children in the first year of life. So the immune system of a child is, trained to respond to different antigens, and that's why for all these reasons, children usually are getting affected less, and even if they are getting affected, they are affected to a less severe extent. And that's why, remember, the disease is less severe, and the mortality and the critical illness is almost nil. Cough and fever are the most common symptoms, followed by sore throat and runny nose, and some children only get diarrhea or vomiting. And fever is less prevalent in pediatric patients. Adults, it's about 90%. In children, fever as a presenting symptom is seen only in 50%. Okay. In fact, in Mumbai, some of my colleagues told me that fever sometimes is not even seen now. And there are atypical cases, as you know, who are coming with multi-system involvement of coronaries, and some involvement of the toes, and so many others. But today we are going to restrict mainly to the respiratory system. We should also be very clear about the clinical timeline of this disease, so that in the first 4 days, the symptoms are variable and they don't require oxygen. In this phase, there is very high viral replication. And on day 5 and 6, it is called a pre-critical period. And here, careful observation is required, just as we observe children with dengue on day 5 and 6. When there is again a problem which begins after day 5 and 6, we have to be very careful in these children also. Some patients deteriorate, some of them they develop hypoxia, and they require high level of care. And on day 7 and 12, between this period, for some critical phase, there will be increase in the oxygen requirements, and during this phase, surprisingly, the viral replication decreases, and then there is a recovery phase. Now, coronavirus or COVID-19 is one respiratory pathogen among so many, but there are many other viruses and bacteria and others which create respiratory involvement. And the real thing is whether you can identify those enemies. And that's why we should know first which are our enemies, which are to be identified during this particular season. For example, if there is onset with cold and sneezing, the mother says only cold and sneezing, then we will suspect rhinovirus. We know that rhinovirus is known as common cold. It mainly involves the upper airway. There is either mild or no fever, and the child is not exhausted. Child plays well. So that is one rhinovirus known as common cold. We are not worried. So if there is common cold, less fever, so less likely to be coronavirus infection. Influenza, parainfluenza, respiratory syncytial virus, all these, they start with common cold-like presentation, like sneezing and runny nose. Now, in case if a child has flu, then there is our influenza, then along with high fever, there will be prominent headache, the child will have myalgia and extreme exhaustion. So this is how one should remember that it differentiates from rhinovirus. Though there would be runny nose and sneezing, these three, they differentiate the virus from others. And we know that there is a virus like, say, adenovirus, which produces problems like pharyngoconjunctival fever or diarrhea or involvement of the mesenteric lymph nodes or hemorrhagic cystitis. So it has a different clinical picture. In case if a child is less than a year, we all know that respiratory syncytial virus, RSV, is the one which creates problems in children. And, either it can affect the child in the mild or a moderate or a severe way in the form of bronchiolitis. And for COVID-19, as I told you, fever with dry cough is an important presenting feature. And some other enemies, which are bacteria, like for example, streptococcus. It will produce fever with follicular tonsillitis and a tender cervical node. If it's a pneumococcus, it will produce pneumonia, where the child will have fever, grunting, and tachypnea. And in case if the progression is very rapid and the child is toxic, we may suspect staph. And if a child is above 5 years and he has predominantly cough, then we will suspect mycoplasma. This is just to give you an overview. Now the point is that we should be very, very clear as to how to differentiate a viral infection from bacterial, though many of our learned colleagues are aware that viral infections usually in the same child affect different systems. That means a child with say viral infection will have runny nose, sore throat, red eye, watering of the eye, rash on the body. Same child will have diarrhea. That means more than one system is involved. While bacterial infections are localized, strep throat, only involvement of the pharynx and follicular tonsillitis, or pneumococcus, only pneumonia. So a child with pneumonia won't have involvement of the pharynx in the form of follicles, something like that. So bacterial infections are almost always localized. Viral infections within one family, more than one person will be involved. That means Dr. Jog will be sick, his wife will be unwell, his children will be unwell, and within the community, wherever I stay, whatever place I stay, other families in that area also will be involved. So more than one system in a child, more than one member in the family, and more than one family in the community, that is viral. While bacterial are usually localized, and within that system also it is only localized to one organ. Okay. And we should also know that if a child complains or rather comes with cough which is much more as compared to fever, many times mothers say बच्चे को बुखार है, बच्चे को खांसी है, and we ask ज्यादा क्या है, so you say रात भर सर इतना खांसता है और बुखार कितना है, नहीं बुखार इतना नहीं है. So that usually indicates hyperactive airway. And if a child presents with fever more than cough, mother says रात भर बुखार था, बहुत बुखार था, खांसी कितनी है, नहीं खांसी इतनी नहीं है सर. So when she says like that, it indicates more of infection. And if it's associated with grunting, we may think of pneumonia or something like that. So these are basics, and roughly many of us by now know that whenever a child has sneeze and wheeze, usually it is viral. Okay. And I'm sure Shishir will elaborate more on the wheeze associated lower respiratory infections, which are associated with respiratory syncytial virus and others. And now let us see child with fever whose mother calls you for a telephonic consultation and is your regular patient with pain in the throat and fever for the last 2 days, and a fever up to 100, and the child also has fever and pain while swallowing food. And there is another child who is 4-year-old with high grade fever, cough, and the mother notices that the child is breathing fast from the morning, and there has been a history of wheezing in the past, and the child has been nebulized couple of times in the past. Here one must remember that in case if someone calls you on phone, please ask them to count the respiratory rate. The best way is to keep a piece of plain paper on the chest wall when the child is lying down, and ask them to count the movement of the paper up and down, counted as one, and for 1 full minute, so that you know that the respiratory rate of 40, 50, and 60 as per WHO at least will be a rough guide. Of course, it's not that simple and not that easy, but then that's one of the ways you can ask them to count the respiratory rate. So we have these two cases, and basic difference is in the respiratory rate. And in case of this second child, the one who says, or when the parents say that there is increase in the respiratory rate, you have to ask them to proceed to a COVID designated facility. You can only give telephonic consultation to children who are having mild symptoms, where you can give them paracetamol or antihistaminic and advise them to have good hydration. Okay. There are quite a few challenges when the child is brought to the OPD with a respiratory problem. As I told you, the child could be an asymptomatic carrier because he doesn't have symptoms, but he is a carrier or an amplifier. Even with mild upper respiratory symptoms, he can be infective to the grandparents or the high risk people at home, that I told you. The child will never keep a mask, and the physical distancing of a child from mother is next to impossible. Physical distancing from the pediatrician is also next to impossible, because we have to go close to the child and examine. And hand hygiene and coughing etiquettes for a child is also very, very difficult. When the child cries, he will release aerosols, and the relatives who accompany the child, they can also infect the entire atmosphere of your clinic. So these, some of these challenges you must remember. And at the back of mind, continuously everybody is afraid, kahin ye wo to nahi, wo is now that corona. Okay, so every person coming with fever, cough, cold is corona unless proved otherwise. That is unwritten dictum these days. Okay, so check the temperature with a digital thermometer in the axilla. Keep the thermometer for 3 minutes. Of course, clean the thermometer after that particular examination of the child is over. Look at the face of the child, whether the child appears sick or non-sick. If a child with fever and cough, he is active, playful, eating well, sleeping well, then it's likely to be a mild viral infection, but he appears sick. Mother says that I give paracetamol, but afterwards the child fever comes down, but child doesn't play. Even when the fever goes down, he doesn't eat. Even when the fever goes down, he doesn't respond to me. So it means that he is sick and likely to have some serious infection. Also, look out for focus, because we want to rule out other infections. So if the mother shows you some pyodermal lesion or a boil, then it is obviously some skin and soft tissue infection. If the mother shows you some pus from urethra, it is obviously urinary tract infection. So there you need not concentrate more on this corona story. Also measure the respiratory rate in your room, and whenever a child is having fever for 4 to 5 days, please do the pulse oximetry, because it has been found that apparently some patients appear well, but they still have hypoxia, and that's why please use pulse oximeter these days. And there are some negative predictors like CRP. If in case if the parents have brought the report and if it is normal, or if the fever is going on for 15 to 20 days like PUO, then obviously we are not dealing with a case of corona. Of course, all these things our learned listeners know about it, but they should be very, very clear about this. And these are some instructions when you deal with a child in the clinic. As you know, keep the baby or the child in the mother's lap or the chair and avoid the table. Many of us have the habit of examining children on the table, but don't do that because of the fear of contact. Use approximate weight and do not weigh on the common scale, because again, one doesn't know whether it has been infected by some other child or whether this child is going to infect. So use approximate weight. Do a quick examination. You can examine from the back of the child, okay, so that he doesn't, throw the aerosol by crying or coughing directly on your face, or hold some tissue paper in front of the mouth of the child, so that even if he cries or coughs, the viruses will be caught in the tissue. Or maybe some of our friends use sterile newspapers. Of course, see that they are thrown off and destroyed properly in an aseptic manner. As I told you, do the pulse oximetry, temperature and tachypnea. If at all you find both these, please send them for testing. And as far as possible, it is said that you should avoid throat examination, because during examination of the throat, aerosol is generated. No nebulization during this period. And I'm sure Dr. Modak will elaborate more on this, on the use of the meter dose inhalers and the spacers. And disinfect the stethoscope, the thermometer, and the pulse oximeter probe with alcohol in between the patients. Okay, and in between two patients, please maintain hand hygiene along with the use of the gloves. Every time you did not remove the gloves, you can take the disinfectant, the sanitizer on your gloves, and continue to examine. Okay, now remember, my dear friends, there is something like an influenza like illness which we are dealing with. And you know that influenza is the head of the family when we say influenza like illness. Okay, the influenza virus basically is divided into A, B, and C, of which influenza A has the biggest potential for spreading the pandemic, and we have witnessed it in 2009, and the world has witnessed almost 5 pandemics since 1918. So remember that whenever you are dealing with this particular coronavirus as of now, as I told you, it is indistinguishable from the other respiratory illnesses. You simply cannot differentiate. I always say that even Rajinikanth cannot differentiate coronavirus from other viruses. Okay, and the only differences which you should know is that the incubation period of this corona, as I told you, is around 5 days. For flu, it is lesser, because the incubation period for corona is up to 14 days, but flu has a lesser one. Runny nose, as I told you, is more in flu, and the mortality of flu, as as far as the statistics is concerned till now, it is 0.1%, while for COVID-19 it is 3%. Many things are not yet known, and I always tell my friends, corona koi jane na. We really don't know this, very mischievous and a naughty virus. Of course, I'll say not only mischievous, but it is a treacherous virus, because in the asymptomatic period also, it is creating problems. So we do not know many things about this virus, but roughly we should know that flu also, okay, flu also is something which you should not forget as an important respiratory pathogen, okay. The monsoon will arrive soon. The flu season will begin in most parts of our country. And remember what happened in US this time in the months of December. Usually it's the peak season for US influenza, but there after this onset of corona, people started taking all the precautions, and because of these precautions taken for corona, automatically the peak of influenza was lesser by 25%, because people did not take the precautions for influenza, they took the precautions for COVID-19, and indirectly the influenza season this time was on the lower side. Of course, this does not mean that influenza has gone down. And remember, it is one important article which has recently appeared in a journal which says that flu virus will produce upregulation of those ACE2 receptors. So they are upregulated, and that's why when your COVID attacks this child who already has flu, it will play a havoc. And that's why, in case if a child is already vaccinated or a person is already vaccinated, this upregulation will not be there. And that's why COVID either will not attack, or even if it attacks, it will be mild. That's why you should get vaccinated. My dear friends, the management of all these children basically includes infection prevention control measures. The cornerstone is supportive therapy. Communicate with parents that it's a mild illness in children, and please act as maternal anxiety relievers, because mothers are always stressed. And whenever a patient comes to you directly for consultation, please tell them that you come after a few days, but please avoid coming directly. Please call me on telephone and give the details of the follow-up after 4 or 5 days. Okay, management includes certain things which I have summarized in a small short form, which is patient to give paracetamol, avoid ibuprofen. This I am speaking of a child who has mild COVID infection. So give paracetamol, avoid ibuprofen, give teleconsultation as I told you as far as possible, keep the child in isolation, and ensure hydration. Tell about necessary precautions for an older child like mask, and also tell danger signs. This is very important. When the child goes out of your clinic, please see that on the prescription paper you write 1 or 2 or 3 things. One, danger signs explained. Number two, nasopharyngeal swab SOS, and report on telephone SOS. Okay, so these three are important so that you are medically safe. If a child is hospitalized, which of course we are not going to handle as general pediatricians, remember the other mnemonic, that is corona. So that you rule out bacterial infections and also know about the lymphopenia part of this virus. Also check for CRP, because everyone knows now it's high in corona. Look at the coagulation profile for the reasons that I told you earlier, and send the blood for culture and some other cultures if available. Give oxygen if the child has hypoxia. Restrict the fluids to almost 80%. And remember that flu can be a coexisting respiratory virus. That's why oseltamivir is a must for any child with increase in the respiratory rate. No nebulization, MDI with spacer is better, and use antimicrobials and antipyretics, because if a child has pneumonia, does not mean that it's be related to this virus, but it could very well be our usual pneumococcus or H flu which have produced this pneumonia. So giving antimicrobials like amoxicillin or ceftriaxone is our duty, and also give antipyretics. So my dear friends, remember, at the end I will tell you that immunize children, see that they are protected against important respiratory pathogens like the pneumococcus by giving the pneumococcal conjugate vaccine at 6 weeks, 10 weeks, and 14 weeks. Give them flu vaccine at 6 months and 7 months, and the yearly flu shot, and also give them measles vaccine in the form of either MMR or MR at 9 months and 15 months. Of course, please see that you immunize them against all the vaccines right from birth in the maternity home. The 6, 10, 14 usually hexavalent with rota and pneumo, the 6 and 7 months influenza, the 9 months MMR, and that 15 months chickenpox vaccine, because we have seen that chickenpox cases also have started coming. Remember to give these primary vaccines with priority now. Boosters and others vaccines can wait for some time. Okay, and also remember that you get yourself immunized. So take pneumococcal conjugate vaccine. Also take the flu shot yourself, because many of us who are in the senior category, that 60, 65, 70, 80, all these, it's a play of numbers. But, when it comes to the disease, you have to be very, very careful. So, my dear friends, please take proper precautions. And I request Dr. Shishir to continue with this particular presentation and take the panel discussion further. Thank you. Yes, I think Shishir, you can start.
Sir, you will have to unmute.
Shishir, on
Unmute.
the left side of your screen at the bottom, there is a button called unmute. So please unmute.
I have unmuted.
Okay. Now you are audible.
Yes. So good evening, friends. My topic is asthma and wheezing under 5-year-old children. It has nothing to do with COVID. It's usual. These are the usual cases which we see every year in certain months of the year, particularly in monsoon season and winter season. And as the rains will start, we will face wheezers every day in and out. So it's a very common condition and all of you are familiar. I'm just going to go through quickly because I have limited time and this wheezing and asthma is a vast topic. So I will restrict myself to diagnosis and some principles of treatment and not all the details. So we know that asthma is a recurrent cough, recurrent wheeze, and there are nocturnal symptoms in asthma, right? So keeping this in mind, I'll show you some cases. So here is a 9-month-old boy who has recurrent wheezing every month since last 4 months. It starts with cold, cough, and fever. Symptoms increase during night, so nocturnal symptoms are there. But he has no eczema, so allergic markers are not there, and he has no family history also. So you remember here 9 months, a small boy, and he has associated fever with URTI-like symptoms. So it is most likely to be what we call VALRI or virus-associated wheeze, and it is not asthma. We wonder whether it is asthma because it's happening again and again. But since it is fever and URTI associated, most likely it is viral-associated wheeze, or previously we used to call it VALRI. So there are different wheezing presentations, which we call as phenotypes. So there are transient wheezers. So this classification has kept on changing. And this is the old classification, which is called as epidemiological classification, which Martinez had proposed several years ago, several decades ago, so to say. So this transient wheezer is a viral associated wheeze usually. They begin wheezing before 3 years of age, and usually, as we know, they outgrow wheezing by about 5 years. Viral infections like RSV or rhinovirus, they act as trigger. And often they are febrile episodes. There is no family history, no atopy, no atopic dermatitis. They have low initial lung function. That means their bronchioles are small, narrow, right from beginning, right from birth. And so they get blocked easily. Since it's not an allergic condition, their Ig levels are normal if anybody does it. And it's not really asthma, it's a viral associated wheeze or VALRI. This is the commonest phenotype which we see. And isko bal dama bhi kehte hain. So this viral associated wheeze, usually children outgrow by about 5 years of age. And since it is not a classical asthma, their response to bronchodilators is also variable. In this Martinez classification, there are various categories, like as I described you, early wheezer. In these early wheezers, sometimes the remission occurs by 3 years, but some children keep on wheezing up to 6 years also. Then it is called as prolonged early wheezer. Some children wheeze beyond 6 years, then it is persistent wheezer. And there is late onset wheezer. That means if they start wheezing after 3 years, they are late onset wheezers. And sometimes onset maybe after say 1.5 years, which are called as intermediate wheezer. But nowadays, this classification is not used commonly. There is other way of classifying these wheezing phenotypes. And this is a classification which is proposed by European Respiratory Society. And they have divided into 2 categories, episodic wheeze and multiple trigger wheeze. So episodic wheeze means there are discrete episodes. They are viral induced. And these children are normal between episodes. That means every episode is separate. And child is normal in between. Suppose one episode occurs in August and other occurs in December. Then in between, there is no interval symptoms. So that is episodic wheeze. Whereas multiple trigger wheeze, wheezing in response to different stimuli other than URTI, other than viral infection. So it may be laughing, crying, exercise, activity, smoke, etc. So some other stimulus is there, and that is known as multiple trigger wheeze. Now, if a child comes, say, at the age of 1 year or 2 year with recurrent wheezing, can you predict whether the child will have asthma in later life? Parents usually ask us whether my child will be asthmatic later. So there is a asthma predictive index, and this modified asthma predictive index is often used. It is applied whenever there are more than 4 wheezing episodes in a year, and there are major criteria and minor criteria. So major criteria is physician diagnosed atopic dermatitis. So eczemas should be there, or physician diagnosed parental asthma, asthma in mother or father, and allergic sensitization to at least one aeroallergen. So these are considered as major criteria. Whereas minor criteria are wheezing unrelated to cold, means without any viral infection, if child starts wheezing, it's a minor criteria. Eosinophils more than 4% in circulation, and allergic sensitization to milk, egg, peanut, etc. So considering the recurrent wheezing, you apply these criteria, find out from the history, and if one major criteria or two minor criteria are present, it is said that it is positive. The problem is here the specificity is not very high for positive index. That means positive predictive value is less, maybe about 50-60%. But negative predictive value is very high. Means if none of these factors are present, then it is likely that child will not have asthma in later life. So you can reassure the parents that there is no parental history, no atopic dermatitis, none of these criteria, then your child will mostly outgrow your wheezing illness. Now, GINA in recent guidelines has changed this classification of phenotypes. What GINA says now is that these phenotypes are not fixed. They are not airtight compartments. They are dynamic. So they can change from one to other. I mean, suppose initially we thought it is viral associated wheeze. It can change to multi-trigger wheeze later on as the time passes. So they are not fixed compartments. And so they have made 3 boxes. This first box is corresponding to our viral associated wheeze, and the third box corresponds to multi-trigger wheeze. If I read this box, it says that symptoms lasting for more than 10 days. That means the symptoms are prolonged. Then there are more than 3 episodes, and they are usually severe. And between episodes, child always has some symptoms, some cough, some wheezing, some nighttime awakening. So child is not very well controlled during the interval period. And allergic sensitization may be there, or atopic dermatitis, food allergies, or family history may be there. So this third box corresponds to classical asthma. And so it is mentioned below that most of these symptoms, if the child has, there are more chances of asthma. So this tells you about probability of asthma in under 5-year-old children. Now, there is differential diagnosis also. Not that all that wheezes is asthma. We are always taught that whatever wheezes may not be asthma, and particularly so in young children. So there are asthma mimics, or what we also call as atypical wheeze. So foreign body always should be kept in mind in a young infant. And congenital malformations may be there. For example, some vascular ring may be there, some bronchogenic cyst may be there. So I won't go into all those details, but you should always keep in mind that some congenital malformation may cause wheezing. Usually it is a persistent wheezing and there is no variability. And it starts early in the neonatal period or in early infancy. Vocal cord dysfunction, tracheomalacia, everybody, all the pediatricians know what is tracheomalacia. There is usually a stridor, a typical sound which comes from larynx or trachea, and it can be differentiated from wheezing. And as the age increases, this usually tracheomalacia sounds go away. Bronchopulmonary dysplasia, congenital heart, then aspergillosis, primary CDS. There are many rare conditions, including cystic fibrosis. I can't go into details of all this, but one should always keep in mind that whatever wheezes, you should rule out an alternative condition, particularly so if the child is very young and if the onset is right from neonatal period. Now listen and see this case. There is a 4-year-old boy, history of recurrent cold, recurrent cough in lying down position. He has occasional fever, 3 to 4 episodes in last 4 months. History of snoring, mouth breathing is there. and treatment with salbutamol and budesonide inhalers without much relief. So obviously, there is not much of wheezing, but it is more of snoring and mouth breathing. Whenever we say snoring and mouth breathing, that means we think of adenoids. So he has adenoid hypertrophy, and whenever adenoid hypertrophy is there, there will be obstructive sleep apnea in some children, and this snoring sound will come. Child will not be able to breathe through nose. So this adenoiditis or adenoid hypertrophy can be a comorbid condition of asthma. So comorbidities have to be checked through history and examination. So sinusitis and adenoiditis are usually persistent symptoms. But what happens is, due to partial or inadequate treatment, child goes from doctor to doctor. 4 days he will take treatment with one doctor, he will go to other doctor. And so inadequate and incomplete treatment is given, and therefore this sinusitis may appear to be recurrent. It reduces a bit and again increases. In this sinusitis or adenoiditis, daytime cough is more common, and snoring is present instead of wheezing. Mouth breathing is very classical, and obstructive apnea can occur. And this may be a standalone condition, or it can be a comorbid with asthma. Here is a 5-year-old girl who has recurrent sneezing in early morning. It comes in attacks, runny nose for several days, itching of nose, eyes, watering of eyes, and nose gets blocked, disturbs sleep at night. She has no fever, usually starts wheezing in 2 days. Obviously, it's a classical case of allergic rhinitis, and it is common in children as asthma is common. Allergic rhinitis is also common. It's an important comorbid condition of asthma. 30% of allergic rhinitis patients develop asthma, and about 80% of asthmatics have allergic rhinitis because they share similar allergens, house dust mites or pollen grains or some smoke, fumes, etc. So these allergens are similar in asthma and allergic rhinitis, and so they go hand in hand in many patients. Now, allergic rhinitis being an important condition, we should just quickly see what is the treatment of allergic rhinitis. So one should use second generation antihistamines like fexofenadine, cetirizine, loratadine, and not the first generation like chlorpheniramine maleate, because first generation antihistamines have a sedative side effect and they can affect learning in children. So second generation antihistamine should be used, and that too for a short period. They should not be used in combination with Montelukast. Montelukast is also useful in allergic rhinitis as a controller. Montelukast has to be given as a controller, and therefore it should be given for a period of 2 to 3 months. But antihistamines should be used for a short period, about 10 days, 15 days, till the symptoms come down. Intranasal steroids like fluticasone and mometasone, they are the best anti-inflammatory drugs for allergic rhinitis. They are the best controllers. And in any persistent allergic rhinitis or any moderately severe allergic rhinitis, INS, that is intranasal steroids, must be given, and must be given for at least a period of 3 months. And this is very important for proper asthma control. If you don't treat allergic rhinitis, asthma also will not get controlled properly. So proper control of asthma is achieved by treating allergic rhinitis properly. Other comorbid condition is GERD, gastroesophageal reflux disease. So here nocturnal symptoms are there, regurgitation and vomiting is there, difficult uncontrolled asthma may be there. This documentation of GERD in young children is rather difficult. It can be done through milk scan or 24-hour pH monitoring, etc. But it's not routinely done in day-to-day practice by average pediatrician. It is done only by experts. But if you suspect GERD clinically, then you can give a trial of PPI, that is proton pump inhibitors like lansoprazole. It is worth giving a trial for about 6 to 8 weeks. Now, all this we have discussed, that we have discussed various phenotypes, we have discussed the comorbid conditions, also conditions in the differential diagnosis. So all this should be found out from history and examination, because what happens is in practice, we get hardly 5-10 minutes per patient, and in this short time, it is not possible to get detailed history. But in case of asthma and wheezing, it is absolutely necessary to give more time and to get a detailed history. So you should identify phenotype by just history and examination. You should ask age of onset, frequency, how long it is there, whether it is associated with fever, and whether there are multiple triggers besides URTI, like exercise, activity, smoke, fumes, etc., perfumes. Then are there interval period symptoms, which I already discussed? Is there family history, atopic dermatitis, allergic rhinitis? And what is the response to treatment? This is very important because that can act as a therapeutic trial. If you are suspecting asthma in a young child, you can give salbutamol inhalation through MDI and spacer. And if the child responds very well, then that indicates that child may have asthma. So response to bronchodilator treatment itself is a therapeutic trial and therapeutic modality, diagnostic modality. And to rule out other conditions in differential diagnosis, which we already discussed, tracheomalacia, it is usually since birth. Earlier the age, congenital malformation chances are more. Very sudden onset, then it may be a foreign body. Snoring, it may be adenoiditis. And runny, itchy nose, nasal block, nasal drip, sinusitis. Then signs of recurrent infections are, if they are there, multisystem infection, clubbing, failure to thrive, then one can think of cystic fibrosis. So all these points, you have to dig into the history and ask carefully in all the suspected patients. Now straight away coming to management of asthma under 5-year children. See, the initial treatment of wheezing is identical for all the patients, whether you label it as asthma or not, whether it is viral associated wheeze or multi-trigger wheeze. So inhaled salbutamol, SABA is salbutamol. So inhaled SABA every 4 to 6 hours for 1 to 2 days or till the symptoms disappear. This has to be given to any child who has wheezing. And if oxygen saturation is low, then you have to give oxygen also. Okay, so this is common for all phenotypes. But which children should be put on controller therapy, that is long-term inhaled corticosteroids or in some cases Montelukast. So who should be given controller? So if symptom pattern suggests a diagnosis of asthma, you remember there are 3 boxes in GINA guidelines. So the third box, which was corresponding to multi-trigger wheeze, they are the symptoms of asthma. There is the more probability of asthma. So in such condition, these children should be treated with controller drugs. If they have frequent wheezing episodes, more than 3 in a season, or if the frequency is not much, but episodes are very severe, even if they are viral induced, child needs to be hospitalized or child needs to emergency room treatment. So in such cases also, inhaled controllers, that is inhaled corticosteroid, should be given. If diagnosis of asthma is doubtful, but inhaled SABA is required every 6 to 8 weeks. हर महीने में आना पड़ता है. Monthly wheezing is there. Child is coming every month for same complaint of wheezing and cough. Then also you can give and consider a trial of inhaled corticosteroid. Now, long-term controller treatment in episodic viral wheeze, as I said, only if it is severe or frequent. ICS, that is low-dose budesonide, is the preferred drug. It is beneficial also. What about Montelukast? Montelukast may be tried in viral-associated wheeze, but it's an inferior option. It is proved beyond doubt that inhaled corticosteroid is the best option even for viral-associated wheeze. Intermittent ICS or Montelukast, given for 10 days, 7 days, etc., has limited evidence and it is not recommended. Now, in multi-trigger wheeze or in a child where asthma predictive index is positive or where there is a high probability of asthma, inhaled corticosteroid should be given as a trial and not Montelukast. ICS, and for all practical purposes, ICS means budesonide 100 microgram twice daily. That is low dose budesonide should be given as a trial for at least 3 months. So this is the dosage table. So budesonide MDI plus spacer, or in a small child below 3 years, it should be given with mask, and 200 microgram per day is a low dose. That comes to 100 microgram twice daily. And the device up to 3 years or even up to 4 years, one can give meter dose inhaler plus spacer plus mask. A mask is attached to it. And above 4 years, mask should be removed and straight away it should be inhaled through the mouthpiece. Because mask increases the dead space, and attaching mask is not a very efficient delivery method. So as soon as possible, if the child is able to inhale through mouthpiece, mask should be removed. I have seen that even a 5-year, 6-year-old child inhales through mask. So that's not a good practice. Mask should be removed as early as possible. Now, how long to give this controller treatment? A trial of daily controller treatment is given for a period of 3 months. It must be given for 3 months, not for 10 days, 15 days. I have seen many prescriptions where ICS was given only for 15 days. So it will be of no use. It will not give adequate anti-inflammatory or controller action. So it should be given for a period of 3 months. Inhaled corticosteroid is preferred option. Montelukast is the inferior option. If there is no response, of course, after giving the inhalation treatment, you will call the patient for follow-up. And if the response is not adequate within 4 to 6 weeks, then you should always think of alternative diagnosis. And younger the child, younger the infant, if all the classical features are not present, then one should think of alternative diagnosis like congenital malformation, tracheomalacia, bronchopulmonary dysplasia, etc., etc. And one should further investigate such children. But if the child at follow-up is well controlled on low-dose ICS, that is low-dose budesonide, stop the controller treatment after 3 months. Okay. So many times what we are learned in asthma training module, that this controller treatment should be gradually stepped down every 3 months, 25%, etc. But that is above 5-year-old children. Below 5-year-old children, the treatment should be stopped completely after 3 months without any tapering, right? This is so because there is a chance that child may go into natural remission. There is a high probability that an under 5-year-old child can go into remission on its own. So there is no point in continuing inhaled steroids for years together. Okay. So you give a trial for 3 months. If the child is well controlled, stop the treatment and call them for follow-up. Give them written action plan in the sense that tell them that if the symptoms reappear, you can anytime rush to my clinic and then we have to restart the treatment. And anyway, call them for regular follow-up. If symptoms recur, then restart the controller treatment and continue treatment in stepwise manner as will be discussed later. That is, if child is well controlled and symptoms do not reappear, there is no question of further continuing the treatment. But if the symptoms reappear while follow-up after say 15 days, 1 month or so, you have to restart. And then for a second time, don't stop after 3 months. Then you give treatment as per the steps explained in GINA. So if the diagnosis of asthma is certain, that means symptoms fall in the third box of GINA guidelines. Child is not well controlled or partly controlled, you follow the steps as per GINA guidelines. So these are the steps. I won't go into all the details of this slide, but it's a very important slide. First, you have to every time review the response, assess the child at follow-up, adjust the treatment accordingly. For step 1, means whenever the frequency is very less and infrequent symptoms are there, no controller is required. But if symptoms are frequent, as I explained already, that every month child is coming off wheezing, more than 3-4 episodes in a season, then you have to start with low-dose inhaled corticosteroid, that is budesonide, and give it for at least 3 months. Even if the diagnosis of asthma is not certain, but it is frequent, then also you give inhaled corticosteroid for 3 months and give a trial. If after trial the child is not well controlled at the end of 3 months and all other factors are checked like adherence, technique, etc., no comorbidity, no triggers, then you can double the dose of budesonide. That is, instead of 100 microgram per day, you can give 200 microgram per day and observe and do the regular follow-up. And even if with this treatment also child is not well controlled, and after assessing all other factors, confirming the diagnosis, then you can go still higher for inhaled corticosteroids, or you can add montelukast. Some people add theophylline also, but that is not a drug of choice. But in such a case, you should refer the child for expert advice, because if double the dose of inhaled corticosteroid is also not helping, one needs further investigations and expert opinion may be given. So as far as this wheezing in under 5 years is concerned, I will give certain take-home messages. That is, identify phenotype of wheezing. As I said, whether it is episodic wheeze or multi-trigger wheeze, or as per new GINA guidelines, whether it fits in first box or the middle box or the third box. Rule out alternative diagnosis. Whenever the child is young, if the symptoms have started right from the birth or from the first month of life, or if the wheezing is persistent, or if the wheezing is unilateral or monophonic, that means the same type of persistent wheezing, then it is likely to be some other condition than asthma. Look for comorbidities like allergic rhinitis or sinusitis, adenoiditis, etc. Treat that condition. And all this could be achieved clinically, because under 5 years, we can't do spirometry, we can't do peak flowmetry, and objective diagnosis is not possible. So it has to be done through clinically by history and examination, but it is possible. If you take a detailed history, by history and examination also you can identify the phenotype. And then if the child is in third box of GINA guidelines, if he has multi-trigger waves, if he has interval symptoms, he has prolonged and frequent symptoms, then treat with inhaled corticosteroids for a trial of 3 months. And that has to be done with the selected children, not all the VZ children. And with this, the child will definitely improve and his quality of life will definitely improve. Thank you very much. I'd like to take questions later on. Thank you.
Okay, Dr. Warad, I think you can start your presentation.
Yes, sir. So good evening. So after completing, like Lok sir said about the occurrence of the infections, specifically respiratory infections, so today we will be discussing about the specific respiratory immunity. But while coming to the specific respiratory immunity, it is always related to the general immunity also. So I will start with some of the, like how the acute respiratory infections, Lok sir has already highlighted about how it is affecting children, the parents, even the socioeconomic costs. Now, if you see, there is all shutdown and it will have long-term impacts. I will concentrate on basically like how, as an immunologist, how the indoor and outdoor pollution that plays a big role, because in the indoor pollution, even Bodak sir also said about the dust mites and all, they are a big problem now. This season also, the infections, as the children are at home, the infections have gone down. But the allergic cases have also gone up, because when I get calls, the reason is that most of the family members are at home and they are continuously exposed to the sofas, curtains, and cushions in the bed and all, and so that the dust mite exposure is more. Even if you see the things, how in our day-to-day practice also, respiratory, upper respiratory infections, the children come. This season is Corona, but besides that also, as the rainy season will start, or in the winters, we get a lot of upper respiratory infections and lower respiratory infections. And how these infections are related to the immunity, because many times when the parents they talk to us and when they cross over, they will always start with that कि डॉक्टर साहब मेरे बच्चे की इम्यूनिटी कम है, पहले से ही वो बीमार पड़ता है. But is it related to that? See, here you can see like how the it is not a primary immunodeficiencies, but it is basically the low levels of immune parameters. So how these immune parameters are affected because of the defective phagocytosis and chemotaxis of the macrophages and neutrophils, decrease TLR function and ciliary functions, dendritic cell immaturities, decrease in the immunoglobulins, these all classes, decrease in the CD4, CD8 natural killer cells, alterations in the cytokine productions by lymphocytes, IL-4s, then IFNs, interleukin 12, and then this is very important, but T-regulatory TH ratio as well as TH1 and TH2 ratio. Next slides I will highlight on in details on that. So this schematically, if you see, the same thing has been explained in a simpler way. So these are the important points we have to keep in the mind. So 1, 2, 3, 4, 5 that. So these are interleukins and different type of receptors and all, interferons, and then CD4 natural killer cells. See, what will be the consequences of these respiratory infections? This will definitely damage the respiratory mucosa. As we know, suppose there is a big wound on the skin, the wound will be healed, but there will be always scar. The same way, if the child or anybody, adult or somebody, has a severe infection and it is affected over there, pneumonia or the mucosal damage, it is going to be persistent. The infection will go away, but the scar will be there, and then again the child will be exposed to the recurrent infections, and the severity of the second infection, the chances are high. Then again, antibiotic use, resistance, the steroid use is very high, then quality of life and economic burden. So these are the factors. Some of them will be repeated again, as Jog sir and Bodak sir has already said, but I will highlight on these issues like atopine allergies. 30% of children are having this. And even in the infancy, early onset, 44% of children see that. And these are the rare things. These all primary ciliary dyskinesia, cystic fibrosis. These are also common again because of the tonsil adenoids and infections, the eustachian tube obstructions. And even in India, if you see, many of the children, they have a bad habit of sniffing inside. So what happens because of that, again, it goes into the sinuses, the mucus. If it is infected, again goes to the eustachian tube, and this will have a chronic inflammation. This inflammation will have a post-nasal dribbling and irritate the airways. So this again has a cycle. So again, cardiovascular abnormalities, food allergies causing the inflammation to the GI tract, malnourishment, lifestyle change, deficiency of the vitamins. Then cesarean born children have a bacterial flora deficits, as well as the reduced breastfeeding in these children because they are exposed to the top feeds in the early stage. So the bacterial flora is altered. And again, they will be exposed to the pathological bacterial flora in the NICU or in the hospital. So that will be again a problem. So there are studies by the CRF also in Pune, like cesarean born babies have a more chances of infection as well as allergy. These environmental factors, the climate change is happening, poor ventilation in the rural areas, then chulas in the rural areas are, everything is burned. Even in Pune like city, practically we have found in the slums and these corporation workers and all early morning, they burn the things. So this pollution will create the problem. So in these, again, this Th1 immunity is getting lost in the children because of the families. I mean, there are no same family children exposed to the infections, and this in earlier days the children used to have infections from the same family, so the bacterial flora used to be restored. So they used to have a Th1 immunity. Now what has happened? As the child is born, he is not exposed to the visual infections or to the farm animals. So the Th1 immunity is going down and the Th2 cells are increasing. Again, the previous this seasonality was there, but now according to the lifestyle, as every season, the parents and children, they are eating the ice creams, cold drinks and all. That is causing again secondary infections. The restore food into the freeze, there are documented studies, it causes a lower immunity. Then these vitamin deficiencies, there are therapeutic randomized control trials for that, and the greater predisposition will be to the undernourishment, as well as overnutrition also. Even in Pune or Mumbai, like metropolitan cities, the obesity is a problem. So the obesity will have endocrinal changes, and the inflammation into the body, into the airways will be there. And if the child is having a snoring and all, it will have again obstructive changes, which will lead to the respiratory infections. So the non-breastfed children and these pollutants. So the looking at the overall immunity, we know like stem cells leading to the myeloid and lymphoid cells. These myeloid cells, again, these cells and lymphoid will be T cells, B cell lymphocytes. And these granules leading to histamines, mast cell stimulation. So these all the things in a normal child will control the inflammation, and these are helpful. But where there will be a hyper inflammation or hyper IgE or more histamine because of the allergens and exposure and all, there will be more inflammation, will cause a secondary infections. So if you see the immunity as the child grows, we know that's why we give a vaccines more in the infantile period, so that the child will be having a slowly adaptive immunity to the specific infections. And as he is exposed to the natural infections and to the farm animals and all, he will have a adaptive immunity, and then it will persist to the adolescence and adulthood, and then it will wane off towards the, as jokes are said, after 60 and all, the people will have a lower immunity. So this in the children specifically, it wanes after 6 to 9 months, and that's why we require a booster doses repeatedly. So the vaccines are very important, and routine vaccination also should be continued this period. Now these three factors are very important: adequate nutrition and good hygiene. Now we know, like everyone talking about hand wash and all. I think after this corona will be over, there will be obsessive compulsiveness for the hand wash and all this thing. But when I had been to the ICPP, the International Congress of Pediatric Pulmonology, there I found in Japan also, most of the children or in the airports, people were using a mask without any epidemic. So the mask use and the hygiene will definitely prevent the secondary infections. These all nutrition will definitely is helpful for the immunity. Most of the times the parents expect like we should use some medicines in a form of immunomodulator, but these basics are missed. So we have to again highlight on this to the parents, because now we have a lot of time, the OPDs have gone down, so we can give a time to the parents, which suppose the patient, the parents on the video consultation or telephonic also. Even these all colored fruits and vegetables and cereal pulses we should give to the child. Along with that, the activity of the child is very important. Like we know, like a lot of children are nowadays mobile and digital friendly. Most of the time they are not having any activity. That's why again the immunity will be low. In this lockdown period also, we should ask the parents to continue the activity in whatever skipping or indoor games. At the home also they can have marching or something. Such type of games should be promoted. Even when I had been to National University Hospital Singapore, I found very interesting presentation. And sleep and immune system is very well related. The sleep deprivation, specifically because of the ADHD hyperactive children and because of the respiratory infections, blocker noses or asthmatic children in the night time, most of the time they have attacks. This sleep is deprived, and again it will lower down the immune system. So the studies have been found that the frequent occurrence of the infections such as the diarrhea, dysentery, even any in India like country, malaria, dengue and all, they will lower down the immunity. The multiple episodes of this type of infections will have a malabsorption, decrease in the appetite, and again it will in turn reduce the immunity, predisposing to the severity of the infections as well as repeated infections. So this picture will highlight most of the things where, as already Dog sir said about the vaccines, Bodo sir talked about asthma, infectious diseases. See, this TH1, TH2 ratio, environmental factors, lifestyle, these are all very important. So breastfeeding has to be given, exclusive breastfeeding, even in the cesarean born babies, they should be exclusively breastfed because the colostrum is very important for initial stages, and that will have a long-term impact to the child. And afterwards also, whatever the factors to the breast milk, bifidobacteria and all, they help for promoting the immunity. So if you see, these supplements should be given during this corona epidemic also, and during routinely also. The child should be getting all this zinc for 14 days every 6 months, vitamin D therapeutic doses we all know, vitamin C, B complex, vitamin E, selenium, probiotics. Now again, there are some general probiotics like in diarrhea and all we use it, but now there are a lot of studies now, and there will be specific probiotics to prevent the respiratory infections as well as to reduce the duration of the symptoms and severity of the disease also. And again, there are enzyme therapies like pitotimod, and as I said, colostrum also. Bovine colostrum also has been tried. Some of the studies say it is okay for 28 to 30% patients that way. So, but the specific probiotics now will be playing a big role. As I said, the TH1 and TH2 responses are very important. So, as the child is born with the TH2 cells more, and again, if the allergens are exposed, the child will have a more TH2 and lesser TH1. So this lesser TH1 will have again respiratory infections. This will cause again lower immunity, and if the child continues to the exposures, he will have a secondary complications also. Not only the children and these infections in a childhood, these inflammation persisting will cause adult respiratory diseases as well as other the diet affected, the microbiota affected. And as we know, our children, even the parents, we doctors also are not exposed to the sunlight, because between 10 to 2 o'clock, the zenith angle is there, and that is helpful for the vitamin D receptors in the skin to produce the vitamin D, and that is not, we don't get it. So the supplementations are very important in that. And in the inflammation in the adult, because of the diabetes, hypertension and all, these are the underlying or endocrine disorders will be having inflammation. But allergy is in the top, and that is increasing, and that will cause a more inflammation and lowering the TH1 response. So these, our immune system sometimes plays in a different way, and those allergens like house dust mites and all, and even this summer season now, the Poloptella or Peltophorum, these pollens are very common. Like we call it gulmor jo bolte hai, ya sarkari babula and all. So इनके जो pollens है, या neem trees, then आम के जो pollens होते हैं, these will again cause a lowering down the TH1 cells and secondary infections. So these immune system will be acting against the allergens and leading to the inflammation. So the quality of life of these children is very important. So wherever the infection will be there, 1/3 of the children are suffering with that. Failure to thrive, again behavioral and cognitive disturbances because of the sleep obstructing the nerves or nasopharynx or tonsillar adenoids or eustachian tube, and then OSA-like pictures in obesity children's, and first generation antihistamines, as Modak sir said rightly, the cognitive and behavioral disturbance because of those overuse is there, because we all know, like most of the parents, they will go to the medical store and they will say, give these medicines, because they will feel like last year Dr. Warad has given these medicines, my child was better, why to go to him, just continue that. So self-medication is a big problem in India, and those side effects will be there. And this picture shows a lot, like even WHO has said to stop the newer allergens, newer sensitivities, disease progression, and to control the underlying inflammation. The allergen immunotherapy, which has been practiced since last 120 years worldwide, the awareness in India is very important, because we are talking about these symptomatic drugs with inhalers, mast cell stabilizers, now even anti-IgE antibodies like omalizumab, mepolizumab, dupilumab. There are so many immunotherapies have come up in allergies, asthma, and even now you must be knowing about remdesivir, which has been used in corona. There are other immunotherapies, but the allergen immunotherapy will definitely play a big role to reduce the inflammation in these people, to reduce the IgEs, to improve these IgG for healthy antibodies, to reduce the Th2 cytokines, to increase the Th1 cytokines, and to improve the quality of life. Not only that, these inflammatory cells will be reducing, so the pro-inflammatory markers will be reduced, and the quality of the life of the child will be improving. So these regulatory T cells will have a development of the healthy immune response to the immunotherapies. And not only that, this suppression of the dendritic cells and generation of the suppression of the Th2 cells, Th17 cells, and specific IgEs will be reducing, and the IgG for induction will be promoted. Even now we can measure the IgG for antibodies into the blood to see against the dust mites or pollens. As I said in the beginning, why this season dust mites exposure in the family is affecting the allergens and inflammation, because 1.5 gram of human dander one person sheds in a day. So in a family, suppose there are 4 people, there will be 6 gram of, and 1 gram of human dander or human skin shedded will have a 10 lakh dust mites. So in one bed, imagine how many dust mites, and 6 to 8 hours the person is exposed to that. So we have to act against that, we have to identify that. So there are some specific immunostimulants also against a particular antigens. Then again, non-specific immunostimulants are there, that they will have various effects on the immune system. Immunomodulators will be there, or some of the immunosuppressants also, and biological response modifiers as an immunomodulus at the cytokine level. As I said, remdesivir or these other types of immunomodulators can act on these acute respiratory infections. So how will be the actions of the immunostimulants? Like we know, adaptive immunity takes a lot of time. Innate immunity against some infections, if the mother is vaccinated, like rubella or tetanus toxoid and all, the child will have the immunity against those. But the adaptive immunity, the generalized or the specific, takes some time, and these things play a role into that. So this Th1 cells and reduction in the Th2 cells, this will definitely in turn will have an effect on the plasma cells and antibodies. So they will reduce the frequency and recurrence of the infection. So there are some immunostimulants in respiratory infections which are available, like bacterial lysates, pre or probiotics or symbiotics, enzyme therapies, and as well as herbal remedies are tried. Even you must be knowing now, Ayush and some homeopathic people are there claiming about some of the medicines and all. But till we don't have a proper randomized control trial, we can't believe on that. Even some of my homeopathic good friends are there. I was just seeing their WhatsApp messages recently. They were themselves having a controversies into that. So the epidemic medicine, something has been recommended, arsenic album or something, but they were just analyzing now, and they will be testing the patients later on. So we have to have a randomized control trials for something. Now, along with the, as I mentioned about the selenium, zinc, vitamin D, vitamins, vitamin E, then pitotimod like molecules, then colostrum and all. See, gut microbiota thought to be play an important role, not only the respiratory infections and all, but many diseases. And previously we used to use in diarrhea or malabsorption syndromes, but now there will be a specific probiotics for specific diseases. Even atopic dermatitis or eczemas, there are specific probiotics now. So the probiotics, how the action is there, it modifies the T cell responses, maintains the homeostasis of Th1 and Th2 activities, induces the secretory and systemic IgA secretions. So impact of the microbiota, as I said, on different diseases. So the probiotics will be a future in our practice. So desirable probiotic properties should be withstand the external processing. Maybe at the time of production it will be there, but it has to process throughout the reaching to the child, and not only the child, when child consumes, then the GIT also, or anywhere, wherever it acts, it should be surviving over there. Viable to the gastrointestinal environment, adherent to the gastrointestinal epithelium, antimicrobial substances, as well as modulate the host immune response and metabolism, and demonstrate the clinical benefits. So patient has to get a proper benefits. So there are popularly used probiotics like Lactobacillus acidophilus, Bifidobacterium, Lactobacillus reuteri, Bacillus clausii, Bacillus subtilis, Lactobacillus rhamnosus chichi, Saccharomyces boulardii. All of us know, as the pediatricians who are using, a lot of companies have come up and they are coming to us. But last 9 months, whatever, like I am using a specific respiratory strains, I have found Lactobacillus acidophilus and Bifidobacterium lactis very useful, and specifically in this NSC FM, carefully chosen, and which will have a very good response. Like it acts by the all these different mechanisms. Previous slides I talked about, so that's why it protects against the bacteria and the viruses, as well as it reduces the inflammatory response. Okay, so this IL-10, IL-13, IL-5, these will be reduced with this. So there are some clinical trials also. I will enlighten on these things. So absorb in intestine to the lymphoid tissue, stimulates secretion of IgA, interferon, tumor necrosis factors, boost up the immunity and protect against the bacteria and viruses, and decreases some interleukins like IL-4, IL-5, and IL-13, which will be most of the time responsible for the respiratory allergies and inflammation. So there are again these studies, and I will not go into the details because already I'm the last player and I have to be very fast and quick. So I will go to the direct inferences of the studies. So they analyze for these different type of antibiotic prescriptions and all. So they found like 46% reduction in duration of the symptoms. So the duration of the symptoms is also reduced as compared to the placebo. So the symptom reduction is also there, and the severity of the duration into that child. So here you can see the percentage wise comparing to the placebo. So there are studies done, and again the respiratory infections also, and beneficial effect on the severity and duration of the symptoms. So there are 23 trials involving 6,269 children, and so these children with the probiotic group, so whichever required antibiotic or antiviral was also given, and they found the absent into the day to the school or daycare was lesser in the probiotic group. So the probiotics were better than the placebo in reducing the number of participants experiencing the acute URTI and mean duration of the episodes of the respiratory tract infections. So the same things, these two strains has shown a very good benefits, NCP-FM and the Bio-07 strains. Even my 20 patients I have analyzed for first 3 months, and then this next 3 months. So 6 months I found around 30 to 40% of the children had a very good recovery from the infections, as well as also prevention of the recurrent episodes also less in those. So there are proven safeties. The safety profile is very good with even the FDA has done the studies. So summarizing, so immunity always starts from the healthy mother. So adolescents, children and all, as a pediatricians, we should always guide them for good healthy habits and good nutrition. Not only the malnutrition, under 5 undernutrition is very common in India, but even the obesity which is increasing in the toddler age group as well as adolescents, that is also harmful. Then supplements, macronutrients, those are still 70% of the adolescents will have anemia. So those has to be corrected. Exercise, this lifestyle change has to be improved. Immunomodulators, which are depending on the affordability of the patients, enzyme therapies, colostrum or specific probiotics. Still, the specific probiotics are a little bit costly. So, affordable patients definitely we can use. And as I said, 1/3 of the children which are having allergies underlying and which is causing a inflammation, specifically like chronic respiratory diseases in the children and asthmatic children, 80 to 80% of the children will have allergic comorbid rhinitis. So those patients, the proper allergy testing and immunotherapy will definitely reverse this Th2 to Th1. And whatever the other children which are having an underlying inflammation or any disease, chronic diseases there, specifically debilitating children with some CPs and mental retardation and all, they will have some or the other problems. Those, that primary disease also management has to be done. Even like juvenile diabetes is very common in now India, that is increasing. So that sugar control and all has to be managed with that. Thank you. Thanks a lot.
Thank you, sirs. On the three speakers. It was a nice talk. We have a few questions. We would be taking only questions which are relevant to the topic today. The first question, in fact, this question has been asked nearly about 10 to 15 times. Dr. Jog has already mentioned in his presentation that no nebulization in the current scenario, but this question has come about 10 times up till now, that should we use nebulization currently in the patients, or if not, why so?
Basically, procedures which generate aerosol, okay, they are to be avoided. So there are many things which generate aerosol: coughing, sneezing, crying of the child, everything generates aerosol. And the spread of coronavirus is by the droplets and the aerosols. Even while doing nebulization, there is generation of aerosol. And that's why it is prudent and wise to avoid nebulization, because in a child who has fever and cough, many pediatricians, have a habit of, doing nebulization in the clinic. But then at this particular moment, it is better to avoid and use spacer and a mask. And I think Shishir deals with cases of asthma and under 5 wheezing more often. So I would request him to add if there is anything from his side.
No, as you rightly said, nebulization is not the good modality. Anyway, even without COVID also, nebulizer is an inefficient way of delivering the drug to the lungs. And that's why MDI plus spacer plus mask is the best device to be used under 5-year and particularly under 3-year-old children. So during COVID, it is more relevant, and one should use MDI plus spacer plus mask for relievers as well as controllers. For both the things, MDI plus spacer should be used.
Yeah. Okay. The next question comes from Solapur. This is, what is the difference between SARI and COVID-19?
Now, SARI stands for severe acute respiratory illness. It is one of the manifestations of severe COVID infection. Okay, as I told you, pneumonia, severe pneumonia, and then there is critical pneumonia. But that at the level of severe acute respiratory illness, there is, the use of different kind of medications which we have not covered today. But basically it goes into various forms of oxygen therapy, and maybe a child will require, or the patient rather, will require intubation. And sometimes they will give them prone position, and there are various things related to this. But SARI stands for severe acute respiratory infection. It's a severe form when the disease becomes severe. Even SARS, when it occurred in 2002 and 3, at that time this particular problem was there, but this term has been coined over the last few years.
One more question is, in current scenario, when we cannot examine the throat or we are restricted in our examinations, we may miss some of the signs and symptoms which are of some other grave disease apart from COVID. So what could be the implications of this, medico-legally also as well as ethically also?
See, ultimately the doctor has to use the common sense. If a person calls him on telephone and tells about fever and cough and throat pain, then what he can do is, as I told you, we can use the digital thermometer and ask the temperature. he can use the mobile or the torch of the mobile to show the throat for the parents. That means they can show, and they can ask the parents to touch the lower part of the mandible and see whether the tenderness in the nodes is there. Now this is the maximum that probably you can do on the telephone. Now in case, as I told you, if there is increase in the respiratory rate which is noticed by the parents, then you don't call them to the clinic, ask them to go directly to the designated COVID facility. Secondly, which serious diseases our colleague is worried, that has to be very, very clear. So in case if you do not examine the throat for a while, then you may at the most miss follicular tonsillitis, or at the most you may probably miss some retropharyngeal abscess. But retropharyngeal abscess is more diagnosed by the position of the neck and the CT and other things. So there are very few things which are serious and which affect the throat, except maybe a patch of diphtheria. In case if the child has very mild illness like a mild fever, mild cough, then the throat examination can be avoided. However, if the child is really sick, and of course our learned pediatricians can make out whether the child is sick or unsick, then of course there are other parameters like the CRP by pressing on the sternum, or he can look at the sensorium and so many other things. So it is ultimately a combined decision. Only throat examination avoidance, basically it is for again the same reasons, that avoidance of this generation of aerosols. However, all these things are to be taken into account, and I gave you already the various manifestations of viruses and bacteria, their clinical features. So everything should be taken into account. You can also remember, I did not mention about measles. Measles as a respiratory virus, which is also important, and parents also should look out for that. So, please take all the discussion that we have done today in the proper context of the clinical picture of the child and the disease that you are suspecting. Okay.
We will take the
Vijay, will you please stop sharing the screen, Vijay?
Right. We'll take the last two questions for COVID, and then we move to the other topics. What is the role of steroids, especially in cytokine storm?
See, steroids do not have a role in the mild COVID, but on day 6 or 7, when a person starts becoming severe, in the beginning of this ARDS, steroids have a role, okay? Because the main problem is because of the pro-inflammatory cytokines, and to arrest the progression to ARDS, many people are using steroids. However, this is to be done only by the people according to the protocol for that hospital or for that institute. A general pediatrician is not supposed to give steroids at his level. Okay, so that's only for the patients at somewhere around 6th or the 7th or the 8th day, when you find that the patient is probably going in and heading for ARDS, when the oxygen requirements increase and when the person is starting to become sick.
Last question for COVID. What is the role of antihistamines, especially the first generation antihistamines? Because they are also anticholinergic, it would cause drying up of secretions, production of lesser aerosols.
Yeah, actually, I will partly answer it. In the beginning, along with paracetamol, to control the symptoms and irritability, one may give first generation antihistamines, but now second generation and the third generation antihistamines are available. So it all depends on the personal choice. So it's only in the mild variety of these respiratory infections. Okay. Yeah.
Right. Coming to the second topic of asthma and wheezing, there's a question which is with regards to acute exacerbations, recurrent acute exacerbations in asthma. So how do you treat it? Though, sir, you have already touched upon it once more, because 2-3 times it is come.
So they want the treatment of acute exacerbation.
Acute exacerbations, recurrent acute exacerbations.
Recurrent, see, wherever there is recurrent acute exacerbation, that means asthma is not well controlled. And this child needs controller treatment. So controller with inhaled corticosteroid, as I mentioned, budesonide should be given regularly, morning, evening, that is twice daily. To start with 100 microgram twice daily, but it can be increased to 200 microgram twice daily if the child is getting these exacerbations. So inhaled corticosteroid is a must in such situation in a child who is getting recurrent acute exacerbation. And the management of acute exacerbation at that particular point is a different topic altogether. But just to say in few words that first, frequent nebulization in an emergency room or with MDI with spacer. Secondly, oxygen if saturation is low, and systemic steroid, that is either oral prednisolone or injectable steroids can be given to manage very severe acute exacerbation in the hospital or in the emergency room. But to prevent these recurrent exacerbations, controller treatment with budesonide is a must.
Another question, which is with regards to newer antihistamines, second generation antihistamines like belastin,
Yeah.
which have very recently come into the market. So what
Yes.
is the response of patients to these newer medicines?
What I think is, in fact, I don't have much experience with this new antihistamine, but it is not much superior to fexofenadine or cetirizine or whatever second generation antihistamines are. So though it's a different molecule and new molecule, it is not far superior than existing second generation antihistamine.
Okay. We will take the last question in asthma and wheezing. This is actually a vague question. It, the doctor is asking about any vaccines which are there which would come up in the future for asthma.
There is no asthma vaccine.
Influenza vaccine is what is being talked about here.
There are two issues.
Right.
One is the routine vaccines which we give, for example, pneumococcal vaccine, measles vaccine, influenza vaccine. So whichever vaccines prevent respiratory diseases, those vaccines should be given in a asthma patient and also in other general pediatric population, right? So influenza vaccine also should be given depending on the incidence of influenza in a particular area. Now IAP has also recommended influenza vaccine below 5 years almost universally. And even in an asthmatic patient, influenza vaccine should be given to prevent severe illness. But pneumococcal vaccine, measles vaccine, and all other vaccines which are recommended should be completed on time in a patient of asthma.
See, basically, Miresh, I would like to add something. See, the vaccines means infectious diseases is one part.
Yeah, and allergy vaccines are different.
If you see the asthma,
allergy shots,
asthma, yes, sir. So asthma, if you see in children's, 85% of the children have always comorbid allergic rhinitis, and the allergic rhinitis, 93% of the children will always have some or the other primary prominent allergens like dust mites or some indoor molds or pollens. So those allergen vaccines have been already tried since last 120 years, and last like 2011 as IAP took a lead in allergy immunology chapter, and we are using very aggressively, and we are practically we have got a very good result. So these allergy vaccines will be really useful in specifically allergic asthma or IgA mediated any disorders, specifically allergic disorders. And another one more thing is even in adults also, adult asthma, 65% of the adult asthma always have a comorbid positivity for the specific allergens. So that also should be, the pediatrician should be made aware, because that awareness in India is lacking. Worldwide, those are used very regularly. Yeah.
These allergy vaccines are just like immunotherapy, right? It's a part of
Yes, allergen immunotherapy. Allergen subcutaneous as well as sublingual immunotherapy is also very safe. Now, about 2 years, the children can have it at home also. And we are using and very good results that way.
Coming to the third topic about respiratory immunity, dietary measures, micronutrients, as well as probiotics you have already discussed during the presentation. So I will skip those questions because those were already discussed during the presentation. So apart from this, any newer therapies which are there, which are showing some promise for respiratory immunity? Pediatric as well as adults, because even some of the pediatricians are asking for themselves.
Yes, naturally. That's why I said, remdesivir and all, or some of the Zumabs will be now, the immunomodulators, specifically acting on the cytokines and interleukins. Those are getting tested now. I think today only I saw an article on that in Sassoon and PGI Chandigarh and all. There are trials for 3 drugs. And in USA and Italy and all, they have tried some of the Zumabs. So those will be the future, but the cost of therapy in India will be a problem. Only the promising drugs is the remdesivir, because that is produced by one of the Indian company and they will be exporting to the other countries also. And as some of them, somebody asked about the steroids. So some of the patients, if the steroids are contraindicated, these remdesivir and all, they will be useful. That way.
Okay. Acha, Mayuresh, there is a medication called Sepsivac, which is an immunomodulator which is being tried in Chandigarh. It is actually Mycobacterium W. Okay, so this is being tried for to prevent the serious effects of this COVID-19, and trials are going on in Chandigarh. Okay, now we'll have to be really very fast because the auditory immunity of the is now getting tested. So you can.
Yeah. So just the last question. Okay. What could be the complications of such recurrent respiratory infections happening in children? Last question. Though it is already there in
already, I had.
Yeah, you already had
already in the PPT. Yeah, I had a PPT. Like any single wound also on the skin or the same side. Suppose the patient has a wound, how there will be a scar and the skin will be damaged. The same way in asthma also, we know how the remodeling is happening because of the repeated inflammation also. The infection though definitely will damage the airways. So it may be from the nose up to the lower part of the lungs. So even in the upper airway, if the infections happen, the turbinate hypertrophy and all that will be pushing the deviated nasal septum in adolescence or adulthood. Then sinusitis, and there again comorbid conjunctivitis or eustachian tube defects because of the infection. So these are all interlinked. So they have a long-term side effects also. I mean, infections also.
And Mayuresh, usually what I tell our parents is that, you know, many times they say कि बच्चा बार-बार बीमार होता है, so I tell it's a good thing. It indicates that the immunity of the child is good. So you don't worry. You know, many times, you know, otherwise it is known that 6 to 8 times in a year, children, they get viral infections. So there is nothing great. So in fact, if they are getting repeated respiratory infections, in a way, I usually tell them, don't worry. It shows that your child has good immunity. Of course, take it in a lighter vein after proper medical exam. Okay.
Right. Sir, that is the questions. Anyone would like to add anything?
No, the most important thing is that health education. We have not covered anything about certain HWs. I always say, you know, these days it is the Hasta Pancha Sutri. You know, Hasta means kar is hand. So it is related to corona. Okay. So hand washing, use of hand sanitizers, not touching the hand to the mouth and the nose and the eye, keeping the person at a hand's distance, which of course Punekars have been doing for ages together. That's why in certain parts of Pune, like Sadashipet, the corona incidence is very less. And also using the handkerchief and coughing in the elbow. So all these are important measures for prevention, and that is the HE vaccine, that is health education. Okay, that is most important. Okay, and our listeners are mainly pediatricians, so they know all about it. So 4 important things: take the hand hygiene. Second is use of the mask, coughing in the elbow, and physical distancing, not social distancing, because you know social means, you know, even we stop talking on phone and WhatsApp, then that is social distancing. It's only physical distancing. Okay, so that is okay. And that's all. Most of the other points are being discussed at other webinars, but I am glad that today we focused on the respiratory system, and we could get a lot out of it. Thank you.
Yeah. So
Thanks a lot.
Yeah, so it was a great presentation by all the 3 speakers. So I would like to thank you once again. I would also like to thank Centaur Pharmaceuticals for sponsoring this webinar. So until next time, stay safe. All the best.
Thank you.
Thank you. Thank you.
See you. Bye.